Hello, a very warm welcome to our IFSO Integrated Health webinar. I'm Mary O'Kane. I'm the chair of the Integrated Health Committee and also a dietitian based in the UK. The COVID-19 pandemic has turned our world upside down, and this has proved to be a significant challenge to everyone and one which we're still working through. People with severe and complex obesity still need continued support and access to treatment. So I'm really delighted to be chairing this session in which Yaphet Kassler, registered dietitian, an MSc, an epidemiologist, will present her experiences in treating obesity with COVID-19 times and the challenges and opportunities that it brings. Yaphet specialises in obesity and supporting people going forward for bariatric surgery with nutritional preparation and follow-up. She works at the Israeli Centre for Bariatric Surgery and at a clinic in Tel Aviv. She is a PhD student and her research focuses on interventions to improve dietitian follow-up after bariatric surgery and also to prevent and treat weight regain. In addition, we've got an excellent expert panel. So Dr. Silvioletta Ferraria is a dietitian and has a PhD and MSc in human nutrition. And Sylvia is a researcher at the University of Brasilia and a dietitian at Gastrochirurgia in Brasilia. Sylvia is also the vice chair of our Integrated Health Committee and a member of ASMBS, the Brazilian Bariatric and Metabolic Society, and the American Dietetic Association. Sylvia has published widely and many dietitians are very familiar with her work. Dr. Violetta Mosley is a dietitian and Violetta works in the Obesity and Diabetes Unit at the Hospital Clinic of Barcelona. And her research and clinical duties are in bariatric surgery, obesity, diabetes, and dyslipidemia. Her research work is focused on nutritional deficiencies in individuals with obesity and the association between protein intake and body composition changes during the weight loss induced by bariatric surgery and its effect on weight maintenance. Violetta is also Associate Professor at the University of Barcelona. She has authored numerous book chapters and scientific papers on obesity and bariatric surgery, and again, many will be familiar with her work. Violetta is the president of the Scientific Spanish Society of Nutrition and Dietetics. And then also we have Dr. Lisa Westley, who is an associate professor in the Departments of Psychiatry and Surgery at the University of Cincinnati College of Medicine, where she also serves as the Director of Behavioural Health Services for UC Health Weight Loss. In addition to her research and clinical work at UC, she serves as the Integrated Health President of the American Society for Metabolic and Bariatric Surgery. Lisa and her co-authors also published the SMBS recommendations for pre-surgical psychological assessment of bariatric surgery candidates, and she has conducted over 8,000 assessments over the last 15 years. So we've got a fantastic speaker, 3 expert panelists, and before I hand over to Yaphet, I just want to go through some practical issues. This is going to be recorded and it will afterwards sit in the IFSO Academy page for IFSO members. Yaphet is also going to introduce some polls through a presentation, so please participate in these. And then also you'll see that there is a question button. So please submit your questions. I'll be looking for these, and then I'll also be directing those after Yaphet's presentation to both Yaphet and the presenters. So I'm looking forward to a very lively and informative discussion. So thank you and enjoy the webinar, and I'll hand over now to Yaphet.
Thank you very much, Mary, and thank you for inviting me to speak in this webinar. So I will start telling you about my presentation and what we will talk about today. Let me see just that I can move. Okay. So watching the menu, we're going to talk about the factors affecting obesity and especially about the daily challenges for the people living with obesity. I would like to show you some effective strategies from my experience that can help our patients, and also talk about some food for thought in treating obesity generally and specifically today. So when we come to speak about obesity, we have to first define what is obesity. And today, we know that obesity has been characterized as a disease, and it's a disease of excessive accumulation of body fat. Obesity is a chronic, relapsing, progressive disease process, and it's resulting from multiple, both environmental and genetic factors that are difficult to control by dieting alone. We know this today. Obesity is also classified as having a BMI of 30 or greater, but I think it's important to say that even though BMI is it's the best screening tool we have today, only because it's simple and it's cheap and it's easy to use, but not necessarily the most accurate one, since it doesn't even consider body composition. Obesity is also perceived sometimes, sadly, I say this, as a condition that depends only on willpower alone, and therefore the responsibility for it lays in the patient's hands. We know the sentences that we hear from either people or even from our patients, like, just make a decision and stick to it, or all I need to do is have more willpower, or sometimes people get the advice of just simply train more and eat less. We know this is much more complicated than it sounds. And also it's important to say that people wrongly assume that overweight or obesity can even testify about a person's character or personality. We know there's a lot of bias related to weight, and people may think that people with obesity are weaker and have less willpower, which is of course not true, but it is a very strong stigma that we still have today. So obesity is a disease, and it is a worldwide health concern. It is caused by many factors, and it's also treatable and manageable. And when I say that it's treatable and manageable, I don't mean it in a way that we have to fix the people who are living with obesity, but more that we can help them to live with obesity in a better quality of life, and also with better clinically health results. Obesity is not the person's fault, and it is not the person's to manage alone. It's definitely not about food or diet alone, and it's not cured by a miracle treatment. So we know that many factors influence a person's metabolic balance throughout their life. There are genetic factors, but also some external sources like a person's nutrition, a person's behavior, and even the medications he's taking that can affect his weight. There are socioeconomic factors that can affect obesity, and also many physiological factors like the adipose tissue, the pancreas, the hormones, and the gut microbiota. So obesity is a physical threat in terms of health, but it's also a mental threat in terms of mental health, because we know people's quality of life can be affected by overweight and obesity. And actually, obesity is correlated with more depression. It can be correlated with disability, and people can less and less participate in activities they used to do before. We know that some people who are living with obesity experience a lot of shame and guilt because of their weight and because of their behaviors, and they may even experience social isolation and lower achievements either in work or in the academic field. So more than what we've said now, that obesity is a risk factor for both physical health and mental health, it is important to say that obesity itself is a risk factor for obesity. And I mean this in the term that people who are living with obesity may find it harder because of many, many factors that are in their body today to lose weight and to avoid certain foods because of different responses of the body, and we will go over this in the next slide. So when we talk about obesity, we of course think about overeating, and it's important to divide the reasons for eating. We know we mostly eat when we are hungry, but there are certain types of hunger. There's the body hunger, which is the drive to eat when we feel physically hungry. And this is regulated by hormones in our gut, in the blood sugar, and by fat tissue. And there is also the reward hunger, which is controlled by the brain, and it includes emotional, stress-related, and mindless eating. And when this hunger is in control, we eat even though we're not physically hungry. And we actually use food as an emotional regulation tool. Now, we all do this. This is not just something that people with obesity do and people who are normal weight do not do. Everyone eats even when they're not hungry. Eating is an enjoyable activity, but for some people, it may be very unhealthy and have very unhealthy consequences. So to fully understand the effect of the situation, we need to understand in depth the factors that influence obesity. And we also need to look at how the current situation affects the factors that influence obesity, because now in COVID-19 era, I think people with obesity are experiencing much more challenges, even more than in normal days. So before we go to the knowledge, I would like to ask you a first 4 questions. And the question is, do people with obesity and normal weight people respond similarly to food cues, such as food availability? Is it yes, the psychological reaction is the same, or do you think that no, psychological reaction is different in people with obesity and in normal weight people? So Manuela, if you want to tell me when people have answered the poll.
So far, it's Mary here. We've only got a small number answering, so if people want to continue. So the seems to be at the moment that 81% of people feel that the physiological reaction is different in people with obesity and normal weight.
Okay, thank you, Mary. So can I go on, or do more people need to answer?
I think we move on, yeah, but yeah.
Okay.
Yeah.
So as Mary said, most people think the physiological reaction is different. I actually believe so myself, and I think that science is going to show more and more proof of this as we do more research. And I would like to show you one very interesting research. This is a study that investigated functional brain response differences to food in women with a BMI of either below 25 or over 35, which is severe obesity. And what they did in this study, they presented plateable food to the normal weight women when they were hungry. They told them to come fasting, and then they checked the brain activity in the areas controlling positive reward, and they saw this activity was very high. They did this again after they gave the normal weight women a meal, so they were not hungry anymore. And when they checked after the meal, the activity was low. So the food wasn't perceived as much palatable as it was before. Then they did the same experiment in the women who are over a BMI of 35. And what they saw is that the brain activity in the areas controlling positive rewards remained high, both before and after meal, meaning that the food was still perceived as very palatable without any regard to what either they were hungry or not hungry. So this shows us one difference between normal weight and people with obesity. So this is the difference between the two groups. Another very interesting article has divided the factors that are important for the control of energy balance into 2 groups. So one group on the left is the compensated factors. These are the factors that function in a negative feedback manner to achieve energy homeostasis. It's mostly internal signals of energy intake or expenditure, like hormones or neural signals. And the other group was non-compensated factors. These are mostly external factors, like the availability of food, the cost-benefit ratio, the conditioned cues, the palatability, and social constraints. And they built this mathematical model, and what it showed was that body weight and body adiposity settles at a higher level when exposed to such uncompensated factors, and that this new level of body weight appears to be defended by engaging the same strong homeostatic mechanisms preventing weight loss. So this is regarding a slide we had before, that people who are living with obesity have a harder time to lose weight because the body actually fights to keep the weight steady and not lose it. So let's look back to COVID-19, what's happening today. We say that there are some external factors, and today people are told to stay at home. So there's naturally much more screen time, more physical proximity to the kitchen, and sadly, a lot of our patients either delay or cancel doctors, psychologists, dietitian visits, and if they had some weight loss group, they do not go to these visits anymore. We also see that there are no outdoor activities, or much less outdoor activities, because of the social distancing, or that some people need to be in isolation. There's much more boredom, and there is a decrease in energy expenditure, and people do much less physical activity. We also see today that a lot of the people are experiencing stress and tension and uncertainty and a lot of anxiety. All these are known to increase emotional eating and to increase depression, which means a rise in snacking and eating junk food and unhealthy behaviors. We also know from the small study I've shown you, and also I think from the field and from the clinic, that people with obesity may find it harder to hold back and restrain when food is in front of them, not because they are weaker, but possibly because they have a different brain activity in response to food cues. And this will be very important later on when we talk about strategies for intervention. For a lot of people who are struggling with their weight, stress is a trigger for emotional eating. And as I've said, a lot of people are more stressed at this time. And another important phenomenon that is not talked about, but I think it's happening today for a lot of people, is food FOMO. FOMO is the fear of missing out. It's a psychological phenomenon that is known in different areas. And today, people are stressed and they are told to stay at home. And we've seen these pictures in the television that sometimes they go to the grocery stores and the shelves are empty. We've had this toilet crisis in Israel, I think in other countries as well, where people saw it was missing, so they went and they bought it and they stocked it up. So in Israel, we had this crisis afterwards with eggs, and people used to stock up eggs and buy a lot of them. So when people tend to stock up food, they also tend to stock up everything that is plateable and that they can have at home and feel safe, like a lot of junk food and a lot of snacks and a lot of big packages that can hold for a lot of time. Another important thing to take in consideration when talking about staying at home, working from home, being home all day long and not having any activities is the reward and compensation. People have to decide tens of times a day whether they have to, for example, choose to eat a cookie now, or maybe restrain and hold and not eat it now for maybe losing weight next week. So this is a very hard decision for a lot of people to make because you don't get a reward feedback immediately. Eating cookie now is very enjoyable, but maybe losing weight in a week is not something we can feel now. And for a lot of people, what we see is that especially over time, when we have to make a lot of decisions, availability overcomes cognition. So no matter how many times I will decide that I will restrain myself and I will avoid, if the cake is in front of my eyes, then the availability will probably win the cognition. Another challenge for working people today is that they have to keep on working now when they're at home, and there's a lot of stress, and they have to take care of their family and the household and the cooking. And this may bring the situation to the point that everything that is related to me time, taking care of myself, making healthy food choices, exercising, even meditating, doing something to control their emotions, all these are brought down to the end of the list, and people don't find the time to take care of themselves in times of a crisis. And the last thing I will show you when we talk about people with obesity is the sense of capability, because I think it's very important. We see it in a lot of our patients. The most important factor that will help a person decide whether he is going to pick himself again, try again, even after he didn't have any success, or maybe he had a temporary success, is his sense of capability. When a person feels he's capable of, for example, holding a diet, changing his food habits, then he will try. But after he's had many failures and he's stressed and he's having a hard time with emotional regulation, then he may feel incapable and even give up trying again. So if we take all these factors into consideration and look at how the current situation affects the people who are living with obesity, imagine that with all the stress and all the body functions people now have to decide if they want, when they're like in isolation or when they don't have anything else to do besides being at home, they want to start doing a diet and watching their weight. And a lot of people will feel that this is a very hard choice for them to make, and that sometimes if they have to do it alone, they will choose not to do it at all. So I want to talk to you about some strategies for intervention. Okay, so I see I'm okay with the time. So before that, we will do the second poll, and this is because when we want to help people, we first want them to come to us. And as we know, there's a lot to follow up. And I wanted to ask you what you think are the reasons for non-attendance to schedule dietitian or doctor visits. And the options are maybe work issues like scheduling and taking days off for the appointments, or mobility issues like the residents far from the clinic, or maybe lack of awareness of the importance of, I wrote here post-operative because I work with bariatric surgery patients, but any help for follow-up when we talk about weight loss and weight maintenance. So you can answer either one that you think is the most important reason for non-attendance.
So it looks to me as though one of the high reasons is that people feel that maybe it's a lack of awareness of the importance of follow-up, but also obviously very, very importantly about being able to get to those appointments and taking time off for the appointments. And obviously quite a factor can be the mobility as well and the distance from the clinic.
So you're saying the first factor people chose is lack of awareness?
Yes, lack of awareness of patients about the importance of follow-up was 48%, followed by work issues for scheduling and taking days off for appointments was 40%, and then mobility issues was 12%.
Okay, thank you, Mary. So thank you to everyone who answered. I would like to share with you an interesting research that was conducted here in Israel by my colleague, Ariella. And this research checked the reasons for non-attendance to scheduled post-operative visits for people who have undergone bariatric surgery. And as you can see, 77% say that their work issues was the first reason not to come to the dietitian or to the doctor. After that, 72% say that it was distance to the or mobility difficulties. And then 67 said that they had to wait a long time in the clinic for the appointment. And only 34 say that the meetings did not contribute to them. So this is the reasons that people stated that they did not come. But I think that today the COVID-19 is an opportunity to overcome all these challenges, and this allows people to have some online consulting, and I will talk about this shortly. I want to talk about another reason for non-attendance in the area of what we can do to help our patients. So I did want to raise this subject, even though it's not the main subject, because I think it's so important that we should pay attention to sometimes how us, the healthcare practitioners, have some stigma and bias. And we've known from other research that one of the common reasons for not attending scheduled meetings is weight bias and weight stigma among healthcare practitioners. And patients say that one of the reasons they delay or cancel meetings is because they're afraid they will be judged as weak or lacking willpower, or because they feel shame and guilt for gaining weight. So just when they need the most help because they've gained weight, they may not even contact us and not come because they feel ashamed. And I think that this is a very important thing to say, that when we want to tackle the obesity epidemic, the way to do this is also to tackle the parallel epidemic of weight stigma, because this will help us having better contact with our patients. This will help them come to us more, and then we can help them more. So let's talk about some strategies to help our patients in the COVID-19 era. So I wanted to show you some online virtual nutritional counseling that I've done. I've had the opportunity to do this in the last few months. And I have a private clinic. I always have frontal meetings with my patients, and I've never done online counseling before because I didn't think it was close enough. I wanted to see the person in front of me, and sometimes I thought that maybe if the person wouldn't find the time to come, then he wouldn't take it seriously enough. And I must say that all these thoughts appeared not to be true, and I think this can be very good for our patients as another option for nutritional counseling. There are some disadvantages. There is no face-to-face interaction, and this takes time getting used to. It is a challenge for people who are working from home, especially people who have some small children, to find a quiet place with some privacy so they can concentrate and have this nutritional consult. And sometimes there are disruptions, and we also don't see the person's body language, which is very important information, and the weight is self-reported and so on. These are some of the disadvantages that I've seen, but also there are a lot of advantages and some areas of interest that are new to me. We can see the patient's home environment. I have patients that come to me for 5 years and I've never seen their home, their kitchen, their refrigerator. And for this, I want to say, I think that showing your home and your refrigerator can be something very intimate. So I always ask my patients for permission. I will ask them if they want to show me. And if they do, I think that we can learn a lot from, we talked about food cues before. So how the food is presented, how it is organized at home, what do they have in front of them that is available, where are the snacks and where are they stored. So this is very important information. I think what we want to do in this area is what we do with the COVID-19. We want to flatten the curve of the weight gain or of the eating. So these are some factors that I think that must be taken into consideration. The first thing we need to do is to manage the exposure. We need to see which food is on the eating table, which food is in the living room. If we say that people who are living with obesity tend more to eat with their eyes, then we must attend these places at home. and increase the availability of vegetables and fruits. We always tell our patients to make the junk food not available, but we also have to increase the availability of healthy food. I think we need to help them these times, especially with the food shopping habits, help our patients understand that they do not have to stock up. They can buy one snack every time, and that they need to buy more healthy food than usual because they need it to be at home in a larger amount. And also have more portion control, either by buying smaller packages and eating maybe in smaller plates. What I want to help our patients do is changing the automatic pilot. So instead of eating whatever is in front of them because they're working from home and it's not the usual day-to-day routine, I want them to plan their daily food routine even when working from home. I do this with patients by many types of ideas. Sometimes we even work with WhatsApp log diaries because if they don't want to write me what they're eating, they can picture it and they can send it to me. And then we have a better connection of what's going on, and we don't let it slide into automatic eating. What I want to help my patients do is to manage both the external and the internal environment. So in terms of external environment, we're talking about increasing the availability of healthy and nutritious food, from the shopping cart to what they cook and what they have in the refrigerator. We also want to guide them to decrease the exposure to unhealthy and processed food, again, from the shopping cart to where they put it in front of their eyes when they're at home. And we also want to help them to build a daily schedule with regular meal times, even though they are at home. About the internal environment, this is of course more challenging, and we need to have more tools to help our patients with this. We want to help them manage the thoughts about food and to control the response to the exposure to desirable foods. As I say, not to work on the automatic pilot. And we also want to teach our patients emotional regulation. So food will not be the only thing they use to regulate their emotions. So these are my practical recommendations. I want my patients to have a plan, and I want to monitor their activity, and I want them to regard caloric density and, of course, drink all through the day. I want to guide them now that maybe they have more time because they're at home to prefer home cooking over ordering in, and to regard the food composition and volume because we want them to have long-term satiety. We want to teach them a way not to snack all day, even though they are at home near the refrigerator all day. I want to take into account the responsiveness of my patients to their environment, and sometimes the changes are not in what you eat, it's in how you put the food in your fridge and in your living room. As I've said, I use visual photographed food diaries like WhatsApp because I want my patients to be more frequently in touch with me. And I think people need more approach to professional support, especially at these times. So I do recommend to raise the frequency of nutritional online meetings, maybe even make them shorter but more frequent, because I think our patients need much more help than usual. There are two things that I will only briefly show today because it's not our subject, but we can't go without speaking about them, which is of course the emotional eating. People who are living with obesity, as I've said, everyone has emotional eating, but people who are living with obesity struggle with it harder, and it does have a health effect on them. So we need to give them more tools to deal with this. And the second area, which we won't speak of today, but is also so important, is to help our patients move and tell them that every step counts. What's happening today is that the total energy expenditure has lowered because people do not do even the simple activity of going to the grocery shop, doing a walk in the park, jumping to a friend by foot. People are staying at home and sitting at home, and it's a very sedentary life. So every step counts. And the message I want to leave you with is this. We all have the knowledge about what a person should eat and how to build the diet. But I think we should engage more in helping our patients experience less self-shame and less self-guilt and less inside work, and help them have more self-acceptance and more external cues management and more internal emotional regulation. So this is what I have to you today. And again, I want to thank you for inviting me to speak. And this is my contact information. And if you have any more questions, then I would be happy to answer.
Thank you, Yafet, for an excellent presentation. You've raised many issues. Whilst waiting for the panel to turn back on their videos as well, and we're also waiting for questions from the audience, so keep my eyes open for those. I've got a few questions for the panelists. So just starting with you, Yafet, is that obviously you've talked a lot about the video online conferencing and online calls. How do you manage with the people who maybe haven't got smartphones, haven't got the technology to actually do this? How do you work around that?
Very good question. Actually, we have this problem here in Israel with the religious people who are less working with the internet. And I think that there are not a lot of options because we've all gone online and the Zoom meetings and WhatsApp. I think we should encourage these patients to keep coming if they can, and if it's possible to keep coming to the meetings. And I think we need to build for them a support group, maybe ask for more help from the family and friends, because people, as I've said in the beginning, shouldn't go through this alone. People need help, and they need to understand that it's not because they're weak, it's because they struggle more, and this is something they need to do together. And if they can't come to the doctor or to the dietitian, then maybe they can have a friend or a neighbor or a family member take this together with them for this time.
Yeah, it's difficult, isn't it? Because it's a time when people need the most support. They have the least access to face-to-face. So, Lisa,
Exactly.
Yeah, Lisa, just thinking about your area, especially the psychology side, and for all of us dietitians and psychologists, face-to-face interaction is so important to us. So have you found it in your own practice, working with individuals and having probably less face-to-face?
Yes, in our practice, and I don't think we're unique in the States. In our practice, we're actually doing a hybrid of in-person visits and virtual visits. I'm doing telehealth for established patients. I'm doing phone visits, for their mental health follow-up, and also for pre-surgical psyche valves. We're doing those video visits only. This past Saturday, we had our support group virtually. This is the first time that we've ever done that. I think we had 13, 14, 15 people registered and attend that group. It went extremely well. I like many clinicians, had some concerns about, would it feel as connected? Do we lose the intimacy? Do we lose the body language? And I don't think we did. I found that group to be extremely powerful. We've got some good feedback from persons who had attended the group. So I think that actually moving forward, payers will determine, like they do so many other things, whether or not we can continue to have these kinds of virtual sessions, but I'm advocating strongly for it. You talked so well, Yafit, about the barriers to follow up. Doing virtual visits eliminates a lot of those barriers. If people can't take off work, they can often go to the break room or their car if they have to for a visit. If they have transportation problems, financial issues, it's much easier to do a virtual visit. And I would say in our academic medical center, maybe 80–85% of our patients do have computers, and that includes persons who may be having financial assistance. They also, are doing well. We find sometimes it might be a person of an elder status who doesn't have the education, to do computers. But anyway, I think I answered the question, just that, we're doing the hybrid, and I think that the virtual visits are going very well.
Yeah, I think we're all having to adapt, and I think people are learning new technology, but it is sometimes people being afford to access it as well, isn't it? Yeah. Yes. I think we're all desperate for that face-to-face as well. Yeah.
Yes.
Yeah. And Violetta, just beforehand, we were talking before about that you'd mentioned to me offline that you'd taken a structured survey with your patients about who were attending and what had actually worked with them. So do you want to share a bit of the work that you were doing with us? I think you're on mute. You're on mute.
Yes, sorry about it. Congratulations, Jafid. Very nice talk. Actually, Mary, yes, we were very concerned to know how our patients were living this situation during confinement. So we did develop 3 different focus groups to learn about their needs, what they wanted from the hospital, and what we can do to cover their new needs. And well, we were surprised to see that they wanted to keep the contact with telephone or any form that we offered them. So we did start doing our follow-up by phone. And actually, we, after doing this focus group, perform a survey where we collect the most important points that were discovered during the focus group. And we observed that they gained weight in about 52% of our population, gained weight during confinement, but the weight was especially pronounced in those patients that were not undergone bariatric surgery, or those that were going to under bariatric surgery more than 2 years ago. So people after bariatric surgery behave similarly after long-term follow-up. And thus, within the 2 years after bariatric surgery, were able to control themselves better and avoiding any food use and controlling their eating and food supplies and everything. So that was very interesting. Probably Lisa has something to add to this based on, of their psychology aspect.
Yes, several things to that point. In our program, we, of course, as we all do, strive to do evidence-based practice. There is a fair amount of data in the, not necessarily surgical, but general weight loss literature. You may be familiar with the National Weight Control Registry, the database that's maintained out in Colorado. So we have extrapolated from that for a lot of our recommendations. We have kind of 4 pillars that we teach the patients about, and that is, of course, first and foremost, nutrition. There's a protein gram recommendation and a kcal per day recommendation. So we teach that. We teach that tracking is a must for the rest of your life. It's not something that's optional, it's essential. We also teach an hour of physical movements. Start where you are, do what you can. If you're unable to walk, then do seated exercise. We try to help everybody get to an hour of movement per day. And then, as again, Jafid spoke about so well, this follow-up, we tell them, you need to have follow-up in your clinic. There are data to suggest that the more visits a patient has post-operatively, the better the weight loss and maintenance. And it doesn't seem to matter who they see. you know, a medical practitioner, a surgical practitioner, and our, you know, dietitian practitioner, mental health practitioner, doesn't seem to matter. So we want them to come in. So, and we have a structured follow-up for behavioral health as well. So there are a time frame for the visits for them to come in. So when people are struggling, if they feel that they have at 6 months or 1 year or 3 years reverted back to problem behaviors, we go back to the 4 pillars and we see, how are you doing in each of these areas? And if there's an area that is not being, you know, attended to, then we'll get a plan together to address that. That seems to be helpful for people, and we try to educate patients from the onset that obesity is a disease. It's a chronic disease that very often does recur, and it will require monitoring and possibly additional treatment across the lifespan. So we're educating people that way. So for example, if you had cancer and you know, the goal of your treatment was to put it in remission, if you found a tumor or a bump under your skin, there'd be no guilt about that. You would hurry back to the clinic, you would get a new diagnosis and more treatment. So the obesity disease is like that. There's no shame in having symptoms, you know, recur. And so then again, we go back to those 4 pillars. I hope that was helpful.
Thank you. Busy trying to sort out for some reason the questions won't expand on my screen, and I've got a message from Sylvia to say that she can't take herself off mute. Won't direct anything to Sylvia's way. Unfortunately, my question box is not actually opening up at all, so I can try and see, but meanwhile, have any of the panelists got questions for each other? Sylvia, are you off mute now? Great.
Yes, I am.
Great.
Thank you.
Yes.
So, first, I would like to thank Yafet for the great presentation. It was really, really nice. And it opened, I guess it opened with COVID-19, we opened a new area for us, that is the internet connection with patients that actually are new for us. Maybe psychologists are more used to use internet for appointments, but nutritionists here in my country, it was not allowed. So after COVID-19, we were allowed to do internet connections with patients and internet online appointments with patients. And during your presentation, you talked about a very important point, that is the use of the internet and like self-monitoring devices for obesity population, and it avoids the patients to lose the appointments with professionals due to working problems and traffic and family problems. And I guess we should take advantage for this normal problems that we are living, like the pandemic is terrible. However, we can learn what the internet is doing, like nutritional assessment through the internet is challenging, but we should increase our acknowledgement about that, and we should know how to use WhatsApp and internet and all of these devices and these programs that patients use to evaluate calorie intake, protein intake, are increasing. They are increasing the use, and I guess, I don't know if you agree with me, but I guess maybe we should stimulate them to use more often than these devices, because they can be more aware about what they are eating and what they are doing, and if they are eating an adequate amount of protein. So with the pandemic and the use of the internet, we can be more practical, and people can have more access to nutritionists or psychologists or doctors without locomotion problems. So, and I would like to hear you about that.
What I can do is speaking about it, fits very nicely in with the technology, Sylvia, is Manuela has been WhatsApping me people's questions, so I can actually start on the audience questions if that's okay. Yeah. So one of the questions is a very practical one, is the fact that body weights, I'm getting somebody's echo again. So body weights during COVID, it's very difficult if you can't have face-to-face appointments. So how are people working around getting some of the practical issues such as body weights and the bloods done for people's appointments?
In our practice, and I know it's been a topic of conversation in ASMBS in the COVID webinars that we've done there, sometimes something as simple as having the patient who may be on the smartphone go to their scale at home and take a picture of the weight, or you look with the patient, you know, to the scale for the weight. It's much more sophisticated and expensive, but there are scales that can, you know, broadcast the weights and the different metrics, you know, via internet and have a connection that way. You know, it still, I think, remains to be seen whether or not those weights are going to be accepted, you know, by payers. In many cases, at least in the States, our patients are required to have a certain number of supervised diet visits, and, you know, weights are taken during those visits. And if a visit is done and no weight is taken, you know, that visit is probably not going to count, so to speak, for the patient's requirements. And thus, if the other type of obtaining the weight isn't accepted, then that could actually be another barrier for patients to get to surgery. But that's what we're doing, just trying to make the best of it, you know, right now.
Yeah, it is hard. Anybody else get any other suggestions? Certainly in the UK, I saw that somebody on Twitter had tweeted that their department was doing a drive-in weigh-in for patients. So it's for any clinic at all. And they've got the PPE, they're wiping down, and people could drive and actually get their height and weight checked. And then they're feeding that into the rest of the other clinics that are ongoing. So I thought that was excellent. But any other suggestions? Yeah. So but Lisa, it's quite interesting, and it'd be interesting to see what the others think as well. You mentioned that for many patients, it doesn't matter so much which healthcare practitioner that they're seeing. It's actually about having that contact. So what's the panel's feeling about the optimum number of follow-up appointments that actually helps to support that patient and actually helps to get the best health outcomes? You probably all got different practices, so it'd be interesting probably to hear from all of you. So,
well, if I can share our what we do for routine appointments. We actually, for now, we're keeping our normal appointments, and this is 4 or 5 during the first year after bariatric surgery, and then we keep our follow-up in support groups monthly. Now we are developing them virtually since they ask for it during the focus groups. We learn about that. So I think this kind of telehealth is here to stay, and this will give us the possibility to increase the facilities and to prepare better, to provide a better, follow-up, with taking into account these needs, right? We have to provide ourselves the internet of tools, the internet of things. Have you heard about it? I'm sure the weight that we can get online as the other devices we use in diabetes. All these kind of internet of things will help us to get more objective measures. But again, probably this is not the best. I mean, the best, the more claimed thing that they want. They want our contact, they want the support, and these can be easily met with the tools we have now. But I think we should have to put all together and start developing a different way to approach to them, right? And well, prepare both practitioners and also patients to get this done in the future.
Yeah, and you know, this is something that I think is important to consider, the actual treatment or facility context. You know, we're so spoiled, and we're lucky in my facility, you know, as an academic medical center, we have a lot of resources for our patients. You know, for example, my role, my position, you know, in behavioral health for the program is embedded in the program. You know, I'm paid by the departments, and I am there. In many practices, there isn't behavioral health on staff, and in fact, there's no behavioral health follow-up. There's just a pre-surgical assessment, and then it falls to the dietitians, the medical practitioners. So, you know, we have a robust follow-up, you know, program. I mean, our patients are seen by the surgeon 2 weeks after. They're seen by an advanced practice provider at a month. They have a dietitian class at about 2 weeks. The patients who are high risk, you know, mental health wise, I see them privately at 1 month post, 6 months and 1 year, or a patient who is kind of routine, I'm seeing them at 3 months, 6 months, 1 year. We have the monthly support group. I mean, it's a very robust follow-up. And not all programs, you know, have that kind of support in place. So I think it can be challenging, you know, for especially the dietitian in private practice or the dietitian who is not dedicated to the bariatric program. You know, she or he has to care for other patients in other areas of the hospital. So I think it's very contextual, Mary, is the short version of what I meant to say.
So Sylvia Yaphet, do you have any preferred number of contacts?
Yeah, well, here in Israel, there's a recommendation of 6 dietitian visits for the first year after surgery. It's only a recommendation. They don't have to come. Before the surgery, of course, they do have to come, but afterwards, they do not have to. I think they should come even more. But sadly, we have the data for the follow-up meetings 1 year after surgery, and it's very, very low, it's something about 14% follow-up with dietitian 1 year after surgery. And what I've seen also from some research that we're doing, sometimes I do phone calls to patients in our clinic because we're doing research. So I call them, and when I do call them, they're very happy to hear from me, and they say, oh, I want to make an appointment. What I think is that our patients need some reaching out. We always say, okay, you know, you have to manage your disease, but these are special patients, and they do need more reaching out. They do need more guidance that this is a chronic disease which needs a lifetime follow-up. And from my experience, when I did offer them, they were very happy. And I must say that in the last few months, in the COVID-19, a lot of my patients who have stopped, followed up, contacted me and wanted to come back. So I think people are more concerned about their weight. And I think that something should be done nationally for the reaching out to these patients so we can make them come to more follow-up visits and understand that it's a lifetime thing and not monthly for 6 months and that's it.
And I've got a question from the audience, which sort of ties in with probably one of Lisa's earlier topics as well. But in this, the person's written to saying this trying time of confinement, social isolation, fear of infection. Are there any public service reach out programs that attend to individuals suffering with obesity, having antisocial tendencies, living alone, and actually lacking those technologies? So I know certainly in the UK we've had issues with people are shielding. They've had there's been a government scheme where they can actually be provided with some food packages, although the patients might say that might not be their usual choice of foods, and access to things like fruit and vegetables are really difficult. Yeah, you mentioned about buying food in bulk, but fruit and veg doesn't last very long, and also certainly in the UK it's very expensive. So how can we actually help this very vulnerable group who maybe haven't got access to the technology, haven't got the social networks? What way can we work with our populations? Any
Is it a question
examples?
for someone specific?
Pardon? It's just
Is
how.
it a question?
Yeah, so we've got a very vulnerable group, some who are actually having to shield, are really socially isolate. For those people, it's more difficult to actually shop. They maybe haven't got those social networks that the people have. And what can we do as healthcare professionals to support them?
I think we could take advantage to show them how to prepare food with frozen vegetables. I mean, in this moment, especially during confinement, we don't need to, focus only in fresh fruit and veggies. We have them frozen. We have many ideas, or to help them to cook tasty and fast if they want with frozen vegetables, and we could help them to develop that kind of resources, of recipes, or whatever they have in the kitchen. As Yasir mentioned before, right? The telehealth is easy. I mean, it helps us to know exactly what do they have at home. We can just start a conversation focusing on individualizing their grocery, whatever they have already in the refrigerator, and we can help them tailoring the way to cook, depending on what they have and what they know, and how many people are sharing the table with him or with the patient, etc. So I think this is a good opportunity. A lot of people have been cooking more, enjoying the kitchen, right, during confinement. This was seen in the entire world. So this is an opportunity to start to develop new ways of cooking, actually, and it doesn't need necessarily use fresh veggies.
Yeah, it is.
Yeah, and if I may add, sadly, this is a problem even before COVID. Many of our patients who don't have the socioeconomic advantages that other patients do are struggling to get fresh foods. They're having, if they're on, I'm not sure what it's called in the UK or, Israel or Spain, if it even exists, but, if you're having public assistance, for groceries and for food, it's a very small amount, and oftentimes patients explain that eating processed or convenience foods is more affordable. They can get it with their assistance. If I could create a dream bariatric surgery program, I would probably create our own, and I would add sort of what it would be like a community type of social worker or someone who could assist, with resources. We typically don't discharge a person from the hospital to an unsafe environment, to, a place where they're not going to have the follow-up care that they need, at least not in psychiatry, we wouldn't. And so, I think this is more of probably a political action, a public service kind of an announcement or movement that we could do, but we could certainly reach out to the patients in our own program and try to connect them, with somebody in the system who might be able to plug them into some resources. It's not something any of us have the bandwidth or even the expertise to do, but that might be something to think about. It's a problem, and we want to try to help, even if we can help one person at a time. It's good.
But I think also that this can be a workshop that can be easily done virtually. So we in the kitchen cooking, teaching them how, and sharing with them, everything. But in a healthy way. And well, this can be new for them too. So.
And that's excellent. So then moving on to another topic, and it's quite an area for discussion in the UK at the moment, because we've just, the government have launched its new obesity strategy. And one of those is actually about food labelling and labelling calories in restaurants. And that's created a whole big debate. Whilst it might be helpful for some people, it may be helpful, not helpful for those people who've actually got disordered eating or restricted eating. So one of the questions we've got is that how do we get the balance between people tracking their food intake, keeping food diaries in some sort of way, and actually would that actually make eating disorders worse, disordered eating worse, especially if they're counting calories? And how do we actually get that balance between self-monitoring and actually making sure we're not actually making things worse? Any views on that? Yeah.
I fear that you all are going to get tired of listening to me. I think with I think from the behavioral background, it's just a little more helpful. I have seen a few patients over the years who felt that the food tracking caused them to be obsessive, and it was more detrimental for their care, for their day-to-day regimen than it was helpful. Those people are in the minority, in my experience, and I think that for them, what we've done is either reduced the amount of data that we ask them to get. For example, instead of doing an elaborate, online kind of tracker or app, we might say just, look up the 40 foods that you most commonly eat and figure out how many calories and how many grams of protein are in each of those foods. And then each day just write on a piece of paper, your calories and your protein. That's all we need to know. That works for some people, and that's the perspective of our dietitians, how they want our patients to eat. And another idea is to just do audit days. Every second or third day, do your tracker. Every second or third day, do your tracker. That seems to help. But again, I find this to be the minority of patients. If people are resistant to tracking, it's usually because they don't like it or they feel that they don't have time for it. And usually with some education about the value, we're able to overcome that. But it does get tedious, I'm sure, over time.
Yeah, I agree. I think that food trackers are not for everyone. I mean, I feel that we have to individualize and ask with them if they want to do it or not. We should easily explain the benefits, or they can say why they don't want to do it, or they don't feel they want to do it. And then just, encourage that in all of those patients that want to do it and find some reward to do it. It's not a mandate.
I think that food diary or doing a food log, it's not a goal by itself. It's more a tool we have for the patient to be more self-aware. And like I've talked about before, not going through the automatic pilot. So doing a food log is an intervention by itself. And I don't think I agree. It's not for everyone to do it for a lifetime because it is a lot of effort. And sometimes I suggest my patients to, instead of write everything, they can picture it. I think it makes it easier. Or maybe for bariatric patients, they can picture the before and after, so I can see how much they've eaten, and it's easier for them. But I think the main goal is self-awareness. And for some patients, what they learn from the food logs is they cannot allow themselves to be spontaneous around food. You need to have a plan. You need to have a cooking plan for the week. You need to do your shopping. Otherwise, you can see that you get lost in the eating. And it's a good mirror to see. And it's enough to do it every few days and then stop. And then when you're stuck again, do it again. Don't think you need to do it lifetime. Not everyone, please.
Well, time's going on, and it's been an excellent webinar. If each of you is to start to say one thing that has probably this has actually brought the pandemic, something positive that it's brought that it has helped to improve practice. And I know, Lisa, you've got to go first. So do you want to start off first? What's the positive that you've brought from the pandemic? Or a positive change in practice? And
Did you ask me, Mary?
yes, because I know you're disappearing any minute now. So
Yes, I know. I'm sorry. I do have to go.
No.
I think I agree with what you said about its improving practice. I never in a million years imagined that I would be talking to patients kind of in my home, day to day. And I think it's been wonderful for them. And it's allowed us especially to not only support, patients who have already had surgery, who are in our care already, but also to keep engaged with those people whose surgeries got canceled, in the bariatric practices, people who had just started, this new lifestyle change, this new commitment, for us to be able to continue to see them, in this way, even though our clinics were closed. I think it's been extraordinary. It's been good for the patients, good for our practice. Thank you. Also, Yafi, what a great talk. And thank you, Mary, for facilitating. It's a pleasure to be with you all.
Okay. So what I'll do is I'll let Violetta and Sylvia have a word, and then I'll let Yafit have the last word. So Violetta, what's your positive opportunity? And thanks, Lisa, because if you disappear before the end, Violetta, what's the positive thing that you've had?
Sorry, I missed you.
If there's something positive that you want to take from the pandemic, what would that be?
Wow, many things, actually. We discovered a new way to communicate with patients, and we are now in our public hospital developing a new net of communication with them to ask them to give them all that they have been asking during these times, trying to supply the best service from the hospital. And I think they understood that the hospital were worried also for them. So I think this was an opportunity that came for this situation, right? And also help us to understand the value of listen to them, to patients, to ask them, right as the opportunity to get that connection that I don't know if it could have been done without this stressful situation, right? So I think that there's a new opportunity to communicate each other and to give them more resources. And well, we will definitely take advantage of this situation.
And Sylvia, are you able to unmute yourself yet?
Yes.
Yeah.
I am. Thank you. So I totally agree with Violetta. We discovered a new manner to have appointments with patients, and they are getting more accustomed with the devices, and they are more accustomed to use some apps that can help them to evaluate what they are eating, and we can have access to their homes, as Yafit said. And I think we will, later on, we will get more accustomed with this virtual contact with patients, and we will have the choice of having presential appointments or virtual appointments, and it will like increase the adherence with the appointments, I believe.
And Yafit, final words to you.
I think it's a very interesting challenge, like we like to call it, because it's one thing to have constant eating habits, and this is important for us to teach our patients, but it's not enough just to know what to eat every day, same. What our patients need is the ability to work with changes and the ability to be flexible within the borders that we help them build and learn. And it's much more, this is the biggest challenge for them, because they can eat constantly for a while, the same eating habits, but when everything changes and they need to adapt, this is where they need us most. And I think it's the best teaching opportunity. And I hope, looking back, we will all feel we have learned and we can treat our patients better.
Okay. Thank you, everybody. Thank you especially to Yaphet for an excellent presentation, and to Lisa, Sylvia and Violetta for excellent discussions. So thank you very much for participation, and also to the audience for your questions that have come in despite my technical problems with actually being able to see the questions. So thanks very much to Manuela, who is busy in the background sorting out all our issues for us. So thank you, everybody, and enjoy the rest of your day or evening. Thank you.
Thank you.
Thank you very much.
Thank you. Thank you.